Good evening, friends, to all of you who are from India, and good afternoon and good morning for those who are logged in from the rest of the world. Today, our guest speaker is Dr. Naseema Gangat from Mayo Clinic, Rochester, Minnesota, USA. She's going to speak to us on Venetoclax in acute myeloblastic leukemia beyond VIALE-A. This webinar is brought to you by Mumbai Hematology Group, supported by Lucian and managed by Perfect Square. I thank Mr. Srivastava and his team from Lucian, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Naseema Gangat from USA for sparing her time. She has been our regular speaker during last 4 years. I'm extremely grateful to her. All our discussants, who are themselves eminent hematologists or medical oncologists, new participants for sparing your Saturday evening, morning, or afternoon. Tomorrow morning, that is Sunday, 29th of December, we have got 2 lectures. At 10:30 Indian Standard Time, we have Dr. Nitin Sood from Delhi speaking to us about rituximab. And at 11:30, we've got Dr. Neha Kamble speaking to us about myelodysplastic syndromes. Our discussions today include a large number of very important personalities, with Dr. Amit Khurana from Surat, Dr. Anil Singhvi from Indore, Dr. Asif Iqbal from Guwahati, Assam, Dr. Chirag Trivedi from Vellore, Dr. Dev Ranjani Chattopadhyay from Kolkata, Dr. Dibakar Poddar from Kolkata, Dr. Nyaneshwar Upase from Pune, Dr. Ganesh Jashetwar from Hyderabad, Colonel Dr. Kundan Mishra from Lucknow, Dr. Madhura Tinekar Deshpande from Pune, Dr. Malikarjun Kalashetty from Bangalore, Dr. Nilesh Vasekar from Nashik, Dr. Prashanta Bhatt from Mangaluru, Dr. Riya Balikar from Nagpur, Dr. Samir Malinkari from Pune, Dr. Sanket Shah from Ahmedabad, Dr. Satish Kumar from Bangalore, Dr. Shishir Seth from Delhi, Dr. Shaurya Ghosh from Kolkata, Dr. Siddhesh Kalantri from Nashik, and Dr. Sonali Mohapatra from Bhubaneswar. Dr. Naseema Gangat does not require any introduction. You have heard her multiple times in last 4 years, but I'm completing the formalities. She is Professor of Medicine, Division of Hematology at the prestigious Mayo Clinic, Rochester, Minnesota. She received her medical degree from Aga Khan University, Karachi, and this was followed by internal medicine and hematology training at the Mayo Clinic, which she joined as the faculty 12 years ago, that is in 2012. She currently serves as the Educational Chair, Division of Hematology, and Program Director for the Advanced Hematology Fellowship Program. She was named Teacher of the Year by the Hematology Fellows in 2016, 2020, and 2021. Her clinical and research interests are focused on myeloproliferative neoplasms. She has authored or co-authored over 100 papers. Her key contributions to the MPN field include improving prognostication, investigating the connection between mutations and clinical phenotype, and evaluating the novel therapeutics. She has served as editor-in-chief of the American Society of Hematology newsletter. She is currently associate editor for Blood Cancer Journal and editorial board member of the American Journal of Hematology. As said earlier, she'll be speaking to us today on Venetoclax in AML beyond VIALE-A. Thank you so much, and over to her.
Thank you so much for having me this evening. I'm going to just share my screen and get everything situated. Does that look okay on your end?
Yes.
Okay. So I'm going to present today on Venetoclax and AML. I think this is a topic that's very dear to most of us who practice myeloid malignancies. Since it was a game changer for the management of AML, it was approved in the US in November 2018. So kind of a 5-year journey for the drug and what's to come, what's beyond Venetoclax and AML. So I hope this lecture is informative to all those attending, including fellows, trainees, as well as practicing hematologists. Here are a few of my disclosures. and none of them are relevant to this presentation. So the outline of my talk, I'll go through the data which led to Venetoclax approval, the VIALE-A study, which I'm sure a lot of you practicing acute leukemia are familiar with, and then, of course, real-world data, because the medications are approved based on trials which have very stringent eligibility criteria. And we like to see, once the approval has come through over 5 years, how it has performed in the real-world setting. Then the next topic will be outcomes of patients who fail Venetoclax and HMA therapy, because that's a very difficult subset of patients, particularly if there are no targetable mutations. And then finally, I will review a few of the therapeutic approaches for AML that are relapse refractory to the HMA therapy. So Venetoclax has become the standard of care for patients with newly diagnosed unfit AML. And it is usually used in combination with hypomethylating agent, either azacitidine or decitabine. The VIALE-A study used azacitidine as the HMA, but in the real-world setting, actually at the Mayo, 2/3 of our patients received decitabine for the ease of administration. It's a 5-day program as opposed to 7 days for azacitidine. So for that reason, we know that the two hypomethylating agents are comparable, and it is okay to interchange the drugs. Based on this study, the response rates for Venetoclax HMA were 66% CR/CRI rates, which was unprecedented as opposed to treatment with azacitidine alone. And the most important point in this graph is that the survival was improved. Patients on the aza Venetoclax arm had a median survival of about 14 months, and patients receiving aza alone had a median survival of 9 months. So even though the difference appears a difference of only 5 months, it can be quite substantial. And then we're going to go through the data and see which subset of patients benefit the most and in which subset of patients there's more work to be done. This was the long-term follow-up data from the VIALE-A, where the follow-up is close to 4 years, and the survival difference prevailed, which again shows that it's kind of gone through the test of time, that the remission rates and the survival is durable and not short-lived. And this graph kind of illustrates that there are certain subsets of patients that have an improved survival even beyond just when you can take all comers. Patients with IDH1 and 2 mutations in the VIALE-A study had a marked improved survival of 19.9 months versus 6.2 months for the patients who received aza placebo. Here, the comparison was patients receiving the two different arms of chemotherapy. Well, in the real-world setting, I'll be sharing with you data which looks at patients who are mutated versus unmutated, which is actually a better comparison to grasp. And in the AML world, the topic of MRD is gaining a lot of momentum. So when we look at the measurable residual disease here by flow cytometry, and of course, there are many methods of MRD detection that are being evaluated and improved upon over time. Patients who achieved MRD negative remissions, both in arms of the treatment, whether it was Ven-Aza versus aza placebo, had markedly improved survival compared to patients who did not achieve an MRD negativity, which was less than 10 raised to the power minus 3. And then this is a very important study as well, which looks at the quality of life of patients in the VIALE-A study, because it's not just about having improved survival and a higher remission rate. Do these patients actually function better? And there were numerous instruments that were applied to the VIALE-A cohort, and it found that there was a longer time to deterioration of functional outcomes in patients who received Venetoclax plus azacitidine as opposed to azacitidine and placebo. So now moving on to the real world data, and I'm going to be sharing you data from our recent publication, which just came out about 2 weeks ago. So it was perfect timing for this lecture. So 400 patients at the Mayo have received Ven-HMA in the off-trial setting, out of which the CR/CRI rate was very comparable to the VIALE-A study at 62%, CR in 38%, MRD negativity achieved in 70% of those achieving remission. And this table kind of goes through the parameters, like patients with secondary AML had lower remission rates, patients with adverse karyotype, and then it kind of goes through the mutation profile, where patients with P53 mutations, as expected, RUNX1 FIT3 ITD had lower remission rates, and patients with NPM1 IDH2 rather than IDH1 was borderline significant at 0.09, but was mainly the IDH2 mutated patients who had much higher remission rates. And then DDX41 is felt to be a subgroup of patients that are sensitive to venetoclax-based therapy. And here is the latest ELN 2024 risk stratification, which just came out over the last few months, which kind of really relies on a couple of mutations and tells us if patients are favorable, adverse, or intermediate. So the backbone for this is FLT3, RAS, and P53. And patients who harbor P53 mutated patients are the adverse risk patients, so that's easy to remember. And then amongst them, patients who have NPM1, IDH2, and IDH1 have favorable risk disease if they are negative for FLT3, RAS, and P53. And then patients who are either FLT3 positive or NRAS or KRAS positive are intermediate and P53 wild type in that subgroup. So the ELN actually came up with this proposal for patients who are receiving less intensive therapies, because I think we've been quite convincingly showed that the ELN 2022, which was developed for patients treated with intensive chemotherapy rather than low intensity treatments. So what we did was we applied the ELN response predictors to our cohort. And as you can see on the right-hand side, when we look at the higher benefit, intermediate benefit, and lower benefit groups, the patients in the higher benefit group had CR/CRi rates of 73%, but the difference between the intermediate and the lower benefit group was not significant, 52 and 46%, which was more or less similar. And then when we looked at the response predictors that we had identified from our own analysis, the favorable mutations were NPM1, IDH2, DDX41, and the unfavorable were P53, FLT3, ITD, and RUNX1. And as you can see, patients with favorable without any of the unfavorable mutation had CR/CRi rates close to 90%. And if you have an unfavorable mutation without a favorable mutation, it's down to 44%. So that kind of tells you that the venetoclax response rates are quite heterogeneous depending on the genomic subsets that we are looking at. And of course, the ones who are in between are more or less similar. Either you have neither unfavorable nor favorable, or favorable with an unfavorable, and the response rates are in the ballpark of about 60-70%. So based on this, we were able to show that perhaps the ELN 2024 has some shortcomings and needs to be improved upon as we get more real-world data. And here is the survival graphs. The ELN 2024 response predictors are depicted on the right-hand side. And as you can see, the low, intermediate, and high-risk groups, they do separate out. But the 3-year survival for the low-risk group is 34%. And for the intermediate is 21%. And none of the patients in the high-risk group had a 3-year survival. And when we applied the response survival predictors from our own analyses, we found adverse karyotype, P53, KRAS, and KMT2 rearrangements to be detrimental for survival, and absence of IDH2 mutations. So once these are allocated risk points, you can see the separation is much better. Particularly, we're able to identify a low-risk cohort, which are the IDH2 mutated patients with a median survival of not reached and 3-year survival of 67%. And that was kind of missed out in the ELN 2024 model, because they did pay most of the emphasis on the KRAS, NRAS, FLT3, and P53. And once again, the high-risk population has a median survival of 7.1 months, and none of the patients survived 3 years. So it kind of highlights the heterogeneous survival benefits from venetoclax-based therapy. And this is from the same study. Here we look at patients who achieve remission versus patients who do not achieve remission. And once again, patients who achieve CR/CRi had a median survival close to 2 years, as opposed to who don't respond, the median survival is 3.6 months. And we did have a few validation cohorts from the MD Anderson and University of Chicago. And on these, we can once again see that achievement of CR/CRi is critical to have good survival. And then we applied the survival predictors to patients who achieve CR/CRi rather than the whole cohort, because we know that the patients who don't achieve CR/CRi, they do very dismally to begin with. And once again, you get a very nice separation based on the predictors identified. And here, P53 was not factored in because when we adjusted the analysis, it no longer was independently significant. And the 3-year survival for the low-risk patients, which are basically the IDH2 mutated patients without adverse karyotype, KRAS mutation, or KMT2, is 80%, which is extremely good for patients who are being treated with palliative intent. And once again, the high-risk patients have a median survival of less than a year, which would be expected. So even if you achieve CRI, but if you have high-risk features, that suggests your remission is not going to be long-lived, and the likely causes of death are relapse from the disease. So then another area of contention is the duration of Venetoclax. This is in relation to cycle 1 Venetoclax duration. How many days is enough? 14 days, 21 days, or 28 days. And there is ongoing prospective studies, but those are going to take a couple of years to mature. And as we are learning from clinical practice, that 28 days of Venetoclax may be too much, but it depends for which patient and what the situation is. So when we looked at the response rates, they were quite similar based on how much Venetoclax the patients received, whether they received 14, whether they received 21 or 28. But this could be selection bias too in a retrospective analysis because the physician may have truncated the Venetoclax depending on the patient's medical situation at that time. And then when we looked at it based on the ELN karyotype adverse versus non-adverse, once again, the response rates were quite similar in patients with non-adverse karyotype, but with adverse karyotype, the 14-day regimen was a little bit under functioning with a response rate of 22% was opposed to 60% for patients taking 21 days of Venetoclax. So this kind of once again tells me in our practice, we usually tailor the Venetoclax duration, start with 14 days. There may be a role for bone marrow assessment after 14 days, and if the blasts have cleared, to truncate the Venetoclax duration. Because if we keep continuing the Venetoclax for 28 days, it leads to more cytopenias, risk for infectious complications, and anyway leads to cycle delays. So here is a summary slide for the first part of the lecture. We have the genotypic signature for response to Ven. There are the favorable mutations and the unfavorable mutations. NPM1, IDH2, DDX41 are the favorable ones, and unfavorable P53, FLT3, ITD, and RUNX1. And similarly for survival, response achievement is critical and presence of IDH2 mutations. And for the unfavorable, we have adverse karyotype, P53, KRAS and not NRAS, KMT2 rearrangement. And the message is that as we develop newer therapies for AML, all the prognostic models have to be treatment specific. And of course, as we learn more about MRD and what is the best test and timing of measurement, it may be important to incorporate that as well. So how do the patients do when they fail Ven-HMA therapy? And this is again an offshoot of our analysis where we looked at patients who were either relapsed or refractory to Ven-HMA therapy. And refractory are patients who received a median of 2 cycles and didn't respond. And as you can see, once again, we have similar genomic predictors, RAS mutations, ASXL, and P53 mutations. And this again looks like that the mutations usually persisted at the time of relapse. And very few patients are eligible for next therapies after failing Ven-HMA. And only 1 patient underwent transplant. And the survival is really 3 months or less, and you can look at it based on any of the genomic predictors, P53, RAS, or ASXL. I'm going through this quickly because it's kind of redundant that even when you look at it, whichever way you look at it, the survival is quite dismal. And then we came up with another response model. And if you have either of these mutations, your survival is 1-year survival is less than 1%. But if you don't have them, your 1-year survival is 42%. So this is kind of the summary that the treatment options are very limited for these patients in the absence of any targets. So resistance to Venetoclax and HMA is well known, particularly in monocytic leukemias. We know that if you have AML with monocytic differentiation, you're less likely to respond. And then there are monocytic subclones that emerge during therapy. And it is felt that maybe addition of cladribine to the VIALE-A regimen might improve the situation for these patients. So we looked at what we call the CAV regimen, cladribine, Ara-C, and Venetoclax, in a small group of patients, 39 patients who had failed VEN-HMA. The CR/CRI rate was about 28%, and 18% were bridged to allotransplant. And once again, we could see that patients who had KRAS and RAS mutations actually did not achieve CR/CRI, as opposed to some of the other mutations were quite neutral. But this is a small group of patients, so it is hard to draw definitive conclusions. And we looked at the survival after start of the CAV regimen as a salvage regimen. Median survival was 4.7 months. Of course, the transplanted patients did better, but the median survival even in those was about 10.5 months. And if you were not achieving CR/CRI and not transplanted, the median survival was 2.6 months, which is extremely dismal and a difficult situation to deal with. So here's phase 2 data on the CAV regimen in 30 patients. This is a Chinese study. 13 patients had received prior VEN. In this, the cohort I just shared with you were all patients who had received prior VEN-HMA. The CR/CRI rate, once again, was about 27%, and MRD negativity was achieved in about half of the patients. In this study, about 60% of patients were bridged to transplant, which was a large number. So what options do these patients have if they don't, if CAVs can be considered, but now we have other agents that are in development and are approved. The menin inhibitor revumenib was just approved in the US for KMT2 rearranged or NPM1 mutated AML. This is a drug which disrupts the interaction between KMT2A and menin. And this was a pivotal study which was published last year where patients had received multiple prior treatments, prior allo in half the patients, and the response rates were achieved in 30% of the patients, which is a very good number for a very difficult subset of patients. The median duration of remission was 9 months and survival 7 months. 18% of the patients were bridged to allotransplant. And the side effects to monitor are QT prolongation and differentiation syndrome, which was prevalent in a substantial proportion of patients, particularly the QT prolongation, and especially if you factor in other concomitant medications these patients receive. And this is the most recent publication from the Augment 101 study, where, as you can see here, once again, 50% had received prior allo. Response was achieved in 23% of the patients, of which 70% were MRD negative, and 39% were bridged to allotransplant. So this led to its approval, and it's a good addition to our patients who are either KMT2 rearranged or NPM1 mutated and relapsed. So it says about 10% of the patients may harbor these abnormalities, so it only addresses a need for a unique subset of patients. How about IDH inhibitors and IDH mutated? I shared with you that the IDH2 mutated patients do very well with VEN-based therapy, but there'll still be a subset of patients who relapse. And in those patients, IDH inhibitor can be considered as monotherapy. And here, the right-hand side shows you that when we compare the survival between frontline use of VEN-HMA versus IDH inhibitor, it is no different, but the response rates are much superior with VEN-HMA therapy, 72% versus 25%. And partly it could be because of the reason why patients were chosen to receive VEN-HMA versus IDH inhibitor in a retrospective study. And once again, survival is impacted by what kind of genomic profile patients have. So if they don't have an adverse karyotype or they have RUNX1 and BCOR mutations, which were found to be sensitive to IDH inhibitor-based therapy, the low-risk patients, the median was not reached. And the high-risk patients are patients with adverse karyotype or harboring not harboring BCOR and RUNX1 mutations, the median survival was significantly shortened. So this tells us that there's beyond one mutation, there's obviously the impact of co-mutations that needs to be factored in as well. So the direction in which targeted therapies are moving, we are moving towards doublet and triplet regimens. And here's the data on IDH inhibitor triplet therapy, ivosidenib with Ven-Aza. And here you can see the composite CR rates were much higher with the triplet versus the doublet of Ivo plus Venetoclax, and MRD negativity was achieved in 2/3 of the patients. This was a mixture of all myeloid malignancies rather than just AML. And the IDH mutation cleared in 2/3 of the patients when they were after 5 cycles of treatment. So this kind of tells us that if a patient has a targetable mutation, there may be other options, particularly in the form of doublets, triplets, or even as monotherapy, depending on the patient's medical situation. So FLT3 mutation is another one that is present in 30% of AML patients. And what about the use of FLT3 inhibitors in combination with Ven-Aza? Here's data from a phase 1/2 study on relapsed refractory AML patients. They had received Ven-HMA, half of them had received prior Ven-HMA, and GILT in 14%. And the CR/CRI rate with this combination, Aza-Ven-GILT, was 27%. So about a quarter of patients respond. MRD negativity was achieved in about half of the patients. Once again, the remissions were short-lived, about 4 months, but 20% of patients were bridged to transplant. The median survival was quite short, less than 6 months, and particularly in patients who had received prior Ven-HMA or GILT, the median survival was much shorter compared to those who hadn't received that. So once again, there is a paradigm to kind of move towards triplet-based therapies, even though they are not FDA approved. So the administration of triplets has to be done very carefully, keeping in mind that there may be more cytopenias, more toxicities, particularly if the medications are not truncated in the duration. The typical schedule for this program is Ven for about 14 days, and the gilteritinib is continued throughout the cycles. So based on this data, I would like to conclude by saying that Ven-HMA clearly improves the survival and quality of life for newly diagnosed AML patients, the majority of which are elderly and unfit. There are specific genomic predictors of response and survival that inform our treatment decisions. And while we are counseling the patients, it's important to kind of go through the data because all AML is not the same. Relapse following Ven-HMA actually occurs in half of the patients. And half of these patients don't have targetable mutations, and that is a very difficult subset of patients. Okay. CR/CRI is achieved in about 30% of patients with the cladribine, low-dose cytarabine, and Venetoclax regimen. And then there are several promising new therapies on the horizon. The menin inhibitors just got approved. They can be used as monotherapy as well as in combination with Ven-Aza. There are ongoing clinical trials on that combination as well to determine its safety, particularly the duration of Ven and menin inhibitor therapy in that fashion. And then the triplet combinations with FLT3 inhibitors and IDH inhibitors is also gaining a lot of momentum and needs to be improvised, particularly the delivery, in order to minimize toxicity. So I'm going to stop here, and I'm happy to discuss your cases and, perhaps discuss more real-life situations to put this data into context. Thank you so much for your time.
Thank you, Dr. Naseema, for taking us through this journey. We have our colleagues here who would like to ask you some questions, and when they will plan their question, may I ask you one question? Will you like to give your comments about younger people and transplant-eligible patients?
So that's a very important question. In the younger patients, it also depends on the genomic profile. So if they have adverse karyotype or if they have P53, I usually do start with like a Ven-HMA kind of backbone because it doesn't matter how you get them to transplant. We know that even with Ven-HMA, there's been data on some post-transplant outcomes, and we're looking at as well. So it doesn't mean that if they didn't receive prior induction, the thing is, how quickly will you achieve MRD negativity? So if I'm treating somebody more with a curative intent, I would probably do the full course of Ven, the 28-day, rather than truncate it and hope for more deeper responses early on so they can be bridged to transplant. So I think there is a role for this regimen even in the younger fit patients. We just have to work together and identify which genomic subgroups of patients it's going to be most beneficial for.
Okay. Dr. Sanket, please your question.
Thank you, sir. Thank you, ma'am, for this interesting and very informative talk. I have two questions. First is there any benefit if a patient is progressing on aza-ven using a low dose cytarabine and ven? Is there any benefit? That is the first question. And second question is, in some borderline patient, when we start, we feel that the PS is not adequate to start with the 7+3. So we start with aza-ven. Once you achieve the CR, their physical condition also improves. So can we switch over like 7+3 followed by HIDEC? In such patient, we can switch over to HIDEC and to think about cure or something like that. These are the two questions, ma'am.
So I think your first question was whether you can switch to ven cytarabine. Certainly. I usually switch to cladribine, cytarabine, and ven rather than just the ven LDAC. But I think you are able to switch to the low dose cytarabine ven. And the second question is also if you want to treat with curative intent, then it is reasonable to switch. And it depends on what you're treating. Are you treating core binding factor AML, NPM1 mutated AML, where you just want to do like time limited therapy? Because we do know that the response rates are very good with core binding factor and NPM1 mutated with Ven-HMA as well. So if you started with that regimen, usually after about 1 year of treatment, if they are MRD negative by qPCR, we're able to stop treatment. So the Ven-HMA might be okay as well, because if transplant is not... so I think you can do it in many different ways. And we are beginning to learn with the advent of all these medications on how to best use the therapies that are available.
Okay, thank you.
Thank you. One more question. There was little data from France and I think from Mayo Clinic about 7 days of venetoclax. Your comment?
So there is French data. I don't have Mayo Clinic data on 7 days. I'm looking at it currently. I have 14 versus 21 and 28, which I shared with you. The 7-day data is very encouraging too. It's like a 7+7 regimen, like AZA for 7 days and 7-ven. And that has clearly shown that there was no, in fact, it didn't hamper the remission durations. In fact, it was better for count recovery and infectious complications and hospitalizations, etc. So I'm all for shorter schedules, and there's more data on getting shorter schedules because as we are planning to combine triplet-based therapies, we have to move to a shorter venetoclax schedule because it's almost impossible to give 28 days of ven if you're adding a FLT3 inhibitor or an IDH inhibitor or menin inhibitor for that matter.
Thank you. Dr. Shaurya, your question.
Yes, thank you, sir. Good evening, madam. Thank you so much for that wonderful talk. I have a few questions, ma'am, regarding just carrying forward on that question on 7+7. So is it because of the synergism between Ven and AZA that 7+7 is enough, or is there some other mechanism in place? Why 7 days is enough, and then more than that would not be justified?
So we don't know about the synergy between Ven and HMA. That was known, and that led to the development of this regimen. Because venetoclax was originally tried as a monotherapy in AML and relapsed refractory AML, and the response rates were not very good. In fact, the Ven-HMA combination, even in relapsed refractory AML, gives decent response rates, about 40-45%. Why we truncated the regimen is more, like we said, to kind of minimize the toxicities. And if we think this is enough to clear out the blasts, then that may be what is needed. The VIALE-A happened to study 28 days of ven. So kind of the standard practice became, let's give the full month of venetoclax. But as we learned that we see patients that are achieving remission earlier than 28 days, particularly if you're checking their bone marrow biopsy and their blasts have cleared, there's no reason to kind of expand the duration. But I still feel that there may be subsets of patients that require longer duration of ven. So we need to learn more about for which patients 7 days is enough, which patients may need a longer course. But that may be about 14 to 21 days rather than a full 28 days.
Thank you, ma'am. Ma'am, I have a few more questions, if I may ask. Another thing is, like you mentioned earlier, that if we induce with ven and AZA and then take for an allogenic transplant, is there any difference in the depth of remission between the remission achieved with the Ven-AZA versus let's say, a standard induction, even though both patients may be MRD negative? Is there a difference in the depth of remission which may translate to an increased relapse risk post allotransplant?
I think this all needs further study. We don't have any prospective data comparing head to head, but we do know that you can achieve MRD negative remissions with VIALE-A. And in fact, the depth is all determined on what you consider the threshold, right, for MRD negativity. For the flow, we usually use 10 raised to the power minus 3. But of course, if you want to say, well, 10 raised to the power minus 4 or 5, it may be different. But I don't feel like that the VIALE-A is inferior in inducing a depth of remission. I think it just depends on the situation, and particularly patients who are sensitive to treatment, they get deep remission with either therapy. So that's the problem. So there is subsets of patients who won't achieve a deep remission with either regimen, especially the KRAS mutated, KMT, P53 mutated. But the good risk and the intermediate risk patients, for them, either regimen is comparable. And if you can have more outpatient-based therapy, such as VEN-HMA, I think that's preferred for the patient as opposed to so much transfusion needs with 7+3 and HiDAC.
Yes. And how many cycles would you suggest prior to a transplant?
I think a minimum of about 2 to 3 cycles. That much time it requires to even line up the transplant.
Yes.
And I would be very surprised that after cycle 1, any patient is ready. Our transplant group still takes time. So I don't know about the situation in your hospital, but I would say minimum 2 to 3 cycles before transplant.
If I may ask another question. If there's let's say we have we have patients who have a combination of mutations, let's say an IDH2 with KRAS and a RUNX1 mutation. So in that situation, using VEN-AZA is the risk, or when we counsel the patients, is it more of an adverse risk? I mean, does the NRAS, KRAS, or let's say RUNX1 take precedence over the IDH2 mutation?
So in my series, it did not. According to the ELN, the KRAS and RAS do take precedence. So this needs to be, the discrepancies need to be ironed out with more studies and as we use it. Thankfully, with IDH, the RAS doesn't coexist in a lot of cases. When I looked at our cases, there were only 1 or 2 patients who had a concomitant KRAS. And in fact, I didn't find any with the KMT2 and IDH yet in our data set. So thankfully, they don't cluster together. But in case they do, I was not able to find that they were detrimental, but perhaps the numbers also need to be big enough to make meaningful conclusions.
Right, ma'am. And last question, is there any benefit of changing the hypomethylating agent if a patient progresses on VEN-AZA? Like, is there any role in putting the patient on decitabine Venetoclax after failing or progressing on VEN-AZA?
I usually don't do that. But if a patient used prior HMA for MDS, in my cohort, there were at least a subset of patients, about 30 patients, whose MDS was treated with AZA or decitabine, then I would change up when I'm switching to the combination. But if somebody is already on AZA, VEN, and progressing, I don't see much of a benefit to changing out the HMA. I usually switch them to the LDAC, cladribine, VEN regimen, the CAB.
Okay, thank you so much, ma'am. Thanks.
Thank you. I have a question. So if you have a patient who has a targeted AML where either IDH1, 2, or FLT3 mutation is existing. Now, this patient is either elderly or comorbidity or transplant ineligible. What will be your choice? AZA-VEN, or you will use a targeted agent upfront, or you'll use triplet? How will you sequence them or give them together?
I think that's a very important and difficult question because it's very case-based. I usually start with VEN-HMA if they are not extremely frail. If somebody is 90 years old or 85 plus, then I'm more towards doing maybe even monotherapy. Like for FLT3 patient, I've done gilteritinib plus VEN doublets rather than going with triplets. Because if they're not transplant eligible, I don't think I would like to start with the triplet upfront. I'll use the triplet more for if they're not responding. And for the IDH mutated patients, I usually start with VEN-HMA because we know it's very sensitive to it, and use the IDH inhibitor in the next line setting. Or if it's a very frail patient, then I just do monotherapy. And we do know that response rates with monotherapy are there, but they take a very long time. With the VEN-HMA program, at least you respond within 1 to 2 cycles, so you can become transfusion independent and have a better quality of life. So I think the answer to your question is a little bit tricky because it just depends on the patient. But most of the time, if I'm not waiting for the full genomic profile, we would have started them with VIALE-A, and we kind of continue that and kind of wait and see how the response is before we add the targeted therapy.
Sure. Thanks. Dr. Debanjani, your question.
Thank you, sir. That was a lovely talk, ma'am. Thank you so much. So I do have a couple of questions. So, ma'am, like you mentioned that in FLT3 ITD positive patients,
You switch off your video, please. You can't. Your voice is not audible. Switch off your video. Yeah.
Yes, sir, I did it.
Yeah. Now you tell.
Am I audible now?
Yes.
Yes, you are.
Yes. Yes, thanks, ma'am. So, ma'am, you did show us a data cohort where you did tell us about the FLT3 positive group of patients in whom you had used gilteritinib. So, do you have have you ever used midostaurin in these group of patients? Because back in India, it becomes very expensive to use the second generation ones.
I have not been using a lot of midostaurin in this setting. Usually with 7+3, I've been using midostaurin, but it's not inconceivable to use midostaurin. I wouldn't be opposed to it. We just, for us, it's easy enough to get the gilteritinib, and I feel gilt is a little bit better tolerated. The midostaurin has quite a bit of GI toxicity. So personally, the patients have to take more antiemetics and, but it's not impossible to use midostaurin. I think it's just that for the triplets, the data is more for with gilt.
Right, ma'am. So, ma'am, another question. So this is about a patient of mine, a young lady who has relapsed after the primary therapy of 7+3 induction and 3 IDAX in about 1.5 years or so. And at the time of relapse, we found that she was FLT3 ITD positive, KRAS positive. So we started her on, and she was U2AF1 positive. So we started her on aza-ven plus midostaurin. So in this scenario, even after 4 cycles, she was MRD positive. And although the biopsy showed a very small cluster of blasts present. So at this scenario, would you consider taking her up for a transplant at this point of time, or give her a few more cycles of chemotherapy or altered therapy till she clears it out completely?
I think it's better to give a few more cycles of therapy. So because it looks like even though there's not clear disease you identified, there is suspicion, right? So it cannot hurt to kind of be a little bit more definitive, because we do know, like, if you go to transplant with even some disease, then the patient is likely to relapse. So I usually give them time until the transplant and myself are particularly sure that the disease is under the best possible control.
Right, ma'am. Then one last question. Regarding the patients who have already failed the HMA-based therapy, in the group of patients in whom you were suggesting using cladribine, lotocytrobin, and venetoclax. So how severe is usually the cytopenias and the sepsis rates according to your experience?
So the success rate I reviewed is about a quarter of patients achieve response. It can be used as a bridge to transplant. And the cytopenias are there. I mean, it is a little bit more toxic than the Ven-HMA, so they have to be monitored very closely. And the risk for infections, particularly, gram-negative sepsis, etc., has been noted with this regimen. But I think the patients are at risk anyways. They're in a very dire situation. So if we don't do anything about the disease, they're going to succumb to these complications regardless.
Right. Thank you so much.
Thank you. Dr. Naseema, you can stop sharing your screen. So,
sure. Let's see. Stop share. Perfect.
Yeah. Yes, Satish, your question.
Thank you, sir. Thank you, Dr. Naseema, for that excellent presentation. Many practical points. Thank you so much. So we have few patients who, for some reasons, were only on HMA, like azacitidine alone. Maybe they were frail when they came, elderly people who were very frail. So we started only azacitidine, and they tolerated it well, and they went into sort of at least morphological CR. Many patients refused to do a bone marrow after 4 cycles with HMA alone. So they were good on azacitidine, but after 7 months or 8 months, they relapsed. Is there any point adding venetoclax alone at that time when they relapse with HMA and try and see? Is there any data for that? Or would you add cladribine also along with venetoclax?
So they were on single agent HMA, they were responding, and then they relapsed. I would combine it. I would do an HMA plus venetoclax, probably change up the HMA here. So if they're on AZA, then switch them up to decitabine.
Right. Thank you. The second question is, how do you manage MPN blast phase or CMML who have transformed into AML, especially the MPN blast phase if they have ASXL1 mutation? Would you prefer HMA plus VEN, or how do you go about it, who are transplant ineligible?
So this data set that I just presented did not include blast phase because it's a separate disease. The VIALE-A study didn't include blast phase MPN, but post-CMML is included with MDS. In general, I usually put them on HMA-VEN as well. And, the response rates are about 40% CR/CRI rates. ASXL1 is not detrimental in that disease. That's more like patients who have ASXL that transform to blast phase rather than it being a negative predictor. And then if they're not a transplant candidate, it's primarily palliative treatment.
Right. So in CMML, do you prefer decitabine or you still go with azacitidine?
I think I can go with either, depending on what they've previously been exposed to. So we look at that and factor that in as well. Okay.
Okay. Thank you. And the other question is, because the IDH mutation, you showed the data was very good, almost 77%, if I remember, went into CR/CRI. So if you have a young patient, say 40, 45-year-old with IDH1 mutation, no bad prognosis, do you prefer HMA-VEN to 3+7?
I think for a young fit patient, I still would prefer 7+3 because we have a very defined treatment course. And then you finish up with the HiDAX. With the HMA, when it's tricky, you usually do about a year's worth of treatment, then check the MRD. And if the PCR for IDH is negative, then you can discontinue treatment. So I think we don't have good guidance. So if a young fit patient is there with NPM1 core binding factor IDH, I usually just would go with 7+3.
All right. Thank you so much, Doctor. Thank you, sir.
Thank you, Satish. If anybody else has a question, you can raise your hand. Meanwhile, I'll take some question from the audience. So Dr. Hita wants to know your experience about sorafenib as the FLT3.
I have used sorafenib in the long past before we had midostaurin. We used azacitidine as a salvage regimen in FLT3 mutated disease. But now with the advent of midostaurin, gilteritinib, and quizartinib in the US, I have not been recently using it. It's a potent FLT3 inhibitor, we know that, but it does have unique toxicities, skin toxicities, GI toxicities. So in the past, when we had no better options, it was the agent used for FLT3 mutated patients. But recently, I don't have good experience.
Right. Dr. Gopinathan, RUNX1 mutated AML, your experience with HMA plus VEN for 7 days versus VEN for 14 days. These people get prolonged cytopenia. Now, if the patient is 62 years old and he does not have a matched sibling donor, how will you proceed?
This is the patient with RUNX1 that we treated with VEN-HMA and his prolonged cytopenia. I think it would just mean that you have to give less treatment if we think that the cytopenia is more treatment-induced rather than disease-induced. We probably have to lengthen out the cycle duration, 6 to 8 weeks, cut out the VEN schedule. Sometimes I do just 3 days of HMA, like 3 days of decitabine, like a low dose with 5 to 7 days of VEN. So a lot will need to be improvised if the counts are not recovering, And if you've eliminated the disease based on cytogenetics and molecular studies, if they are negative, then you know that it is primarily coming from the treatment rather than the disease, because it's always difficult to know when patients' counts don't recover, that is there a clone that's hiding out, because we do know that patients who don't recover their counts are at higher risk for relapse because of that reason.
Thanks. Dr. Uday Kulkarni has a question. How are the responses to AZA-VEN combination for extramedullary disease like CNS involvement and leukemia cutis?
I think that's also an area that needs further study. There is, I think, small studies, retrospective studies that are published on the subject matter, but I don't think I have any good personal experience on that. The CNS disease, we usually would have to do something else beyond just HMA-VEN. We'd be using intrathecals as well. And, depending on the situation, whether it's a transplant patient or not, then you may want to do more CNS-directed therapy like cytarabine rather than just rely on the venetoclax for that. So I personally don't have like a particular case that comes to mind where I was able to eradicate extramedullary disease with Ven. So a lot needs to be learned. And these are patients who are typically have monocytic leukemia to begin with. So those are the patients that are less sensitive to Ven-based therapy. And just going back to the CMML question too, those are patients that typically the data for the blast phase CMML is like they don't respond extremely well to HMA Ven-based regimens compared to the post-MDS patients.
Thank you. Dr. Gopinathan has another question. If there is a infected AML, can we start only with HMA and add Venetoclax sequentially?
This is a very good question. We have done that quite a bit. If there's a frail patient who's infected, the first cycle sometimes we do with HMA alone. And then from the cycle 2, you could add it, or you could add it a few days later too. I know we like the synergy, but it's okay sometimes if it's a little bit frame shifted. So we have done that quite routinely.
Right. Dr. Hitha has another question. When do you assess MRD on aza-ven? After how many cycles? And in case the MRD is negative, how many more cycles would you like to give? Can we ever stop the treatment or it will invariably relapse?
So this is another very, very tricky, controversial issue. I usually check it at the time of CR/CRi. So if the patient has achieved response, that's the timing, usually about 2 cycles. I usually am not being greedy and hoping that it's achieved after 1 cycle, usually about 2 cycles or so. And I have not discontinued treatment very early on. I usually wait for the whole year. So after about a year's worth of treatment, I may truncate the treatment program, like do less and less of when, maybe lengthen the duration, like 6 to 8 weeks rather than every 28 days. But I have not stopped HMA Ven treatment before the year mark, unless there's major toxicities.
Thank you. Dr. Hitha has another question. Do you transplant all your patients of FLT3 ITD and FLT3 TKD mutations?
So I think the FLT3 ITD is also depends on what the co-mutation pattern is. If the FLT3 ITD is with the NPM1, then I think it depends on the response achieved. And we've also begun to realize that the decisions for transplant don't have to be made just in light of the mutations. It depends on the response, especially if you're still remaining MRD positive, that would make you think, well, transplant might benefit the patient. So it's not all the patients. And for FLT3 TKD, we actually don't transplant based on just TKD. FLT3 TKD with NPM1 is actually a very favorable subset of AML. I know all FLT3 is not the same. And even in the FLT3 ITD, it depends on, how high the VAF was and what kind of response the patients received. So in the era of FLT3 inhibitors, it's almost like Philadelphia positive ALL. We don't transplant all PH positive ALL either, because if you achieve MRD negativity with the TKI-based therapy, same thing with FLT3 inhibitors, then you may be able to get away without a transplant in first remission.
Thank you. There's a question from Dr. Leong about oral azacitidine. Is it a replacement for the injectable?
I don't think the oral AZA is a replacement for the injectable. In fact, thanks for touching on oral therapies. We all like oral therapies because patient can take the medicine at home. They don't have to come into the infusion center, but they are more toxic. There's considerable GI toxicity with both oral AZA and oral decitabine. And oral AZA has been studied in the maintenance setting for patients who were high risk and were not able to get to transplant. So I have personally not used oral azacitidine with HMA in like a frontline or relapse refractory patient. The oral decitabine, sometimes if a patient is living very far away, like 2 hours away from the center, we have tried to use it, but it is more myelotoxic, more GI toxic, and there's also, in the US at least, financial toxicity. It's an expensive pill to acquire.
Thank you. Another related question. Patient is on injectable AZA plus Ven. After a year, can you use oral AZA as the maintenance?
I think that's another area that needs more study. I have not done that, but I'm sure it can be done. It depends, right? If the injectable is being tolerated and if they don't have any problem coming in, I actually prefer that because in my personal experience with the oral AZA used in a handful of patients, they did get a lot of diarrhea and a lot of GI toxicity. So I have not been a biggest fan of the oral formulations for both the drugs, actually.
Thank you. Dr. Leong has another question. Your opinion about Venetoclax single dose as a maintenance, single drug as a maintenance therapy?
I have to formulate an opinion on that, but I think it is a conceivable thing. What is being studied is also weekly dosing, like, doing weekly HMA plus Venetoclax. That was recently published from a group in the US. I think it can be done, but we do know as a single agent, it has limited activity. So usually it is best to combine it with something, whether it's LDAC, whether it's, a targeted drug like an IDH drug or a FLT3 drug. That is better. But if you have to use it as a single agent, I don't think there is any contraindication.
Amit, your question.
So I have two questions on, one is on TP53 positive AML and another on FLT3 positive AML. If a patient of TP53 positive AML relapses on EZA plus VEN, is it a dead end? Anything else we can do after that?
I think all the P53 directed therapies have failed in clinical trials. As you're aware, there were many agents that were being tested, both for MDS and AML. Those are not getting developed further. So it is a very difficult situation. I think in that kind of situation, I would try the cladribine LDAC-VEN. I'd switch it up and see if the patient has somehow become fit. I would try maybe a salvage regimen like, FLAG-IDA-VEN or something if they're going to be somebody you can maybe get to transplant. But otherwise, I don't think the patient has very many options. And those are patients we see too often in the clinic, and they unfortunately do pass away from their disease.
Thank you, ma'am. And second is, if the patient on HMA-VEN, then there were some few data regarding TP53 positive AML that VEN increases the resistance to HMA, and there may also high chance of progression to disease if we go on continuing with VEN in those patients who are TP53 positive in remission. So after 4 to 5 cycles of HMA plus VEN, should we stop VEN and continue with only EZA?
These are patients you're not transplanting, is that?
Not transplanting, yes, ma'am.
Like you would like to stop the VEN and continue with the HMA? I mean, this can certainly be done. We have been doing that, There's been situations when we do that.
Positive AML.
Sorry?
Only for TP53 positive AML.
I think we can do that. I have not personally done that for any particular patient, but I have seen that being done if there are issues with cytopenias or any other complications too. But you're saying that you would want to stop the VEN in the event that they develop resistance to the HMA. Is that what you're saying?
Yes, because there were some trials and data from Australia coming up that VEN increases the resistance to HMA. So once the patient is in remission with HMA plus VEN in TP53 positive AML, should we stop VEN after 4 to 5 cycles and continue with only HMA?
I have not done that, but I think if there is some data and depending on your patient situation, it's not impossible to do it. I think a lot we will learn is by treating the patients, and then you will learn from your experience, right? I don't think we have concrete data on that.
Thank you, ma'am. And one other question on FLT3 ITD positive AML. 65 years old, elderly, unfit for transplant, started on EZA, VEN plus midostaurin, doing very well, in remission for exactly 1 year. Relapses back again, put on single agent gilteritinib, again remission for exactly 1 year, failed gilteritinib, relapses again. What would be your next line of therapy in this setting?
Once again, we have more FLT3 drugs. I don't know if you have quizartinib, but I would try the quizartinib. You can also go back to sorafenib. I think this was brought about in the discussion not too long ago. If the FLT3 levels are still there, you've checked the mutation, because whenever patients relapse, it's also a good thing to reassess the mutation profile, because sometimes when you're on targeted therapy, you suppress that clone, but another clone emerges. So it's always good to kind of recalibrate by checking at least the genomics on the patient. But you're right, if the patient still has the FLT3, then I would go with the FLT3 directed agent. Or you could also try to combine the GILT with the Venetoclax. Have you tried that? Because they were on single agent gilteritinib.
Yeah, only single agent.
Yeah, so I would try to combine GILT with VEN, because there's good data about the GILT-VEN combination. And we will be using that quite a bit here at Mayo, the GILT-VEN combination.
Thank you, ma'am.
Usually I do VEN for 14 days, and then the GILT you can continue.
For 28 days.
Yes, and in fact, you don't have to stop the gilteritinib, It's not like, you can continue it indefinitely. It's almost like being on a TKI.
Thank you, ma'am.
Right. Just 2 or 3 more questions from the audience. One is about antifungals, azole group of drugs with Venetoclax, your dose adjustment.
So at Mayo, it's standard practice to use azoles. The VIALE-A study did not use antifungal, so patients got 400 milligrams of Ven. We usually prefer using POSA, especially if a patient is young and you may consider transplant, and the POSA dose adjustment is 70 of Ven. We round it up to 100 milligrams for ease of dispensing the medication. With fluconazole, the dose of Ven is 200 milligram. And for a very elderly, frail patient who's not transplant candidate, I use fluconazole instead of posaconazole. So that's the standard at Mayo, but I think every center is different. If you use caspofungin or micafungin, then you can use a full dose 400 of Ven, but it's an IV formulation antifungal. So patients don't like to get an IV every day, especially if they're outpatient.
Thank you. Dr. Gopinathan has a question of secondary MDS and AML following Fanconi's anemia, and patient is being planned for transplant. Can you use HMA Ven? Do we have any data to prepare the patient for transplant in this setting?
I don't have data for Fanconi's anemia because, of course, those are rarer conditions. But I would certainly think that it can be used for as a preparation for transplant. I don't think there would be a major contraindication.
Okay. Can you elaborate on the role of Ven-Aza maintenance post-allo transplant?
I think that's another very good question. We have been using HMA GCSF maintenance in high-risk patients. And there are patients where we use the HMA Ven, especially when you know the patient is high-risk, P53, complex monosomal karyotype, and they were able to make it to transplant. There is a good precedence to use those agents as maintenance.
The last question is AML, FLT3 mutated, on Ven-Aza and midostaurin. Patient is MRD negative, does not have a match sibling donor. Can patient be now switched to high-dose chemo plus midostaurin or just midostaurin maintenance?
I think I would just go with the midostaurin maintenance because if they've achieved remission with the triplet combination, I don't see any reason why they need to get a high DAC midostaurin. So just the midostaurin maintenance might be enough.
Okay, so that was the last question from the audience, and I think there is no raise hand sign. If there is one now. Satish, your question.
Sorry, sir. How long have you continued HMA plus azacitidine? How long? I mean, after 1 year, you said you abbreviate, you decrease the frequency, but how long have you continued in your patients, Dr. Nasir?
So these are another very good questions. The longest I've had a patient on treatment was about 2.5, 3 years. That's when the medicine, because when the medicine was approved, there was no duration given to it. And as we are learning, and it's been on the market for 5+ years, now we get more comfortable discontinuing therapy. Initially, I used to be very hesitant to discontinue therapy. If I would discontinue the Ven, I would keep the HMA going or something like in a truncated schedule. So the longest I have done is 3.5 years for a favorable risk patient. And I think now I'm more attuned to, if they achieve MRD negativity, to stop the treatment after a year.
Completely stop both of them at 1 year and then follow.
Exactly, stop it and then keep monitoring. Specifically, if they're NPM1 or core binding factor, it's very easy to follow the PCR, which is a very documented MRD test because the MRD flow is very tricky. It varies between labs and the standardization is an issue. So if there is a qPCR for the patient, like an IDH or a NPM1 or a core, but those are the only ones for which we have a PCR-based MRD test at Mayo. And as we develop more, then it may be easier to kind of stop treatment for patients.
Dr. Naseema, one more question. You mentioned about CBF with FLT3 TKD. I have a young patient, 35, very fit patient with core binding factor and FLT3 TKD. So the TKD came later. So first he received 3+7, followed by HiDAC. Along with HiDAC, we gave midostaurin. 3 cycles of HiDAC is done. And qPCR for CBF is now MRD negative. So can I just continue midostaurin for say 9 months to 1 year and not take him for transplant? Is that good enough?
Yes, I think you can just continue the midostaurin. I don't think just based on the TKD, you would need to transplant the patient. Yeah.
Thank you so much. Thank you so much, Dr. Naseema.
Thank you, Dr. Naseema. I think that's the last question. We took you a lot of time. You really have devoted yourself to us. This may be 4th or 5th webinar you have been doing for us. I'm extremely grateful to you for educating us. Everybody has benefited. Your global audience, all over people have heard you, and it will help the patients. Thank you very much, and have a wonderful
Thank you, everyone. Thank you for your time. Bye.
Bye-bye to everybody.